pleasure today for our seminar series to introduce my close colleague, Dr. David Ludwig. David, why don't you take it over?
All right. Well, thanks, Walt. It's a real special pleasure to speak to the home team. I'll, as Walt mentioned, present some thoughts about the carbohydrate insulin model, and then I look forward to a full airing of what we got right, what we might have gotten wrong, and ways to move the field forward, importantly, to consensus and common ground. These are my disclosures, mainly the books that I've written for the public. The first law of thermodynamics was originally proposed by this German Rudolf Clausius in the 1800s to say that energy can neither be created nor destroyed. When applied to body weight, we have the familiar equation calorie intake minus calorie expenditure equals calories stored, or specifically calories stored as body fat, since that's our main storage organ of excess energy. Now, according to the conventional view, obesity represents a failure to control energy balance. In our modern food environment with ubiquitous, inexpensive, energy-dense, tasty foods, it's easy to take in too many calories. We have a sedentary lifestyle. We don't have the opportunity to burn off the excess. They build up as calorie-rich fuels in the bloodstream, getting forced into fat cells, making them anabolic, and we gain weight. Now, this energy balance model has two consistent central features. First, all calories are alike to the body. And second, to lose weight, you have to eat less and move more in one way or another. This influential textbook said that all diets that result in weight loss do so on one basis and one basis only. They reduce total calorie intake. A scientific statement from the Endocrine Society concluded that the impact of diet on obesity risk is explained largely by its effect on calorie intake, rather than changes of either energy expenditure or internal metabolic environment. Stated differently, a calorie is a calorie. And if all calories are alike, then to treat obesity, we ultimately have to eat fewer of them or burn them off by exercising more. The dietary guidelines for Americans advised losing weight requires adults to reduce the number of calories they get from foods and beverages and increase the amount expended through physical activity. The National Heart, Lung, and Blood Institute has a webpage on balanced food and activity. They reiterate this energy balance equation: more in than out equals gain, more out than in equals loss, and provide the public an estimated calorie requirement chart so that people can get a sense of how many calories they and their family need on a daily basis. The logical translation of this notion of energy balance was the initial food guide pyramid of the 1990s. Fat has more than twice the calories per gram or per bite of the other major nutrients, so it made sense to reduce them as much as possible as a way of reducing energy intake, and instead eat these relatively lower energy-dense foods. You'll recall the first food guide pyramid recommended 6 to 11 servings of these a day. Now, this notion really pervaded the field of nutrition in the late last century. This is just 25 years ago. Statements from society and academic leaders in the leading nutrition journals. One group said, when people are allowed to eat from ranges of high fat or high sugar foods, passive consumption only occurs with fat. It follows that fat promotes overconsumption, while sugar probably prevents it. The second group said, the evidence intriguingly suggests that it is specifically an increased intake of sugars rather than complex carbohydrate that tends to dilute fat energy. And a third group said by decreasing the ratio of fat to carbohydrate, macronutrient balance may be achieved with less emphasis on carbohydrate source. So at that time, fairly recently, all fats were presumed to be disadvantageous to all carbohydrates, primarily based on this notion of energy density. And therefore, foods like this filled up the supermarkets. All of these foods have fewer calories per serving, less fat, and lower energy density than the original, such as the fat-free Snackwells, or my personal favorite, the fat-free half and half. And as expected, calories from fat as a proportion of intake went down, calories from carbohydrate went up, but obesity increased at its most rapid rate during the epidemic during those years. Now, this is just an association, doesn't prove cause and effect. We'll come back to that point a little later. But in any event, we have a worsening pandemic of obesity, according to data from the Non-Communicable Disease Risk Factor Collaboration, as reiterated by Luce. The number of people worldwide from 1975 to 2016 increased fivefold among adults and increased tenfold among children. So we have to step back and ask a big picture question. Why is this paradigm that sounds so simple? Just eat less, move more. 150 calories less a day going in and 150 calories more going out. That's one serving of juice and an extra half hour of moderate intensity walking. That should, by the numbers, take care of the problem. Why has it failed from a public health perspective? Well, one possibility is that the focus on reducing dietary fat was misguided, that the real problem is energy-dense, processed, so-called hyperpalatable foods. One review said the problem is attractive, hyperpalatable, cheap, ready-to-consume food products that are characteristically energy-dense and generally obesogenic. That obesity pathogenesis statement from the Endocrine Society put the focus on highly palatable and energy-dense diets that predispose to excess weight gain. Now, I think we can all agree that this dietary pattern is unhealthy and that many people will not do well in terms of their general health. They'll likely gain weight. But what's the evidence that it's specifically the energy density, the processing, or even the tastiness of these foods that's causing the problem, rather than some other component that we haven't focused on in these statements? Well, this study looked at the issue of food processing, ultra-processed foods, in which 20 young adults were given either similar nutrients, but unprocessed or ultra-processed diets. And then in a crossover fashion on metabolic wards, they were given free access to food and encouraged to eat as much or as little of the respective foods as they wanted over a 2-week period. And the primary finding was that energy intake was substantially higher on these ultra-processed foods. But there was a strong negative slope, highly statistically significant, toward effect attenuation. So that if one simply extrapolated these data another 2 weeks, they would basically vanish, raising the possibility that what's seen in these short studies are transient responses, especially in the artificial setting of a research ward, not a chronic effect. In fact, we know that there are a myriad factors that affect the acute intake of food, especially in research settings, but not the chronic intake in any substantive way. For example, energy density changes, such as those that were obtained in the last study, could explain that entire 500 calorie a day effect. Well, that's been well documented in short-term studies. But energy density doesn't importantly affect body weight or adiposity over the long term. It's never been shown in any long-term study. All of these other factors can substantially influence short-term intake, including utensil size and plate color. But we don't focus public health interventions on small spoons and colorless plates because we understand that these effects really are not going to move the needle for chronic prevention or treatment of obesity. In fact, reviews point out that, such as this on ultra-processed foods, conclusion, it remains unclear whether associations with obesity can be attributed to processing itself or the nutrient content of ultra-processed foods, and the potential for residual confounding is high. This review on variety, palatability, and obesity concluded in humans, no studies have systematically manipulated dietary palatability to examine long-term effects on weight. There is a similar lack of epidemiological studies examining associations between exposure to more palatable diets and weight change, meaning that direct effects on weight in humans remain untested. Let's consider these two foods. Both of them are considered palatable, very tasty, and they're both extensively processed. They're both single macronutrient extractions from plants, olive oil and a sugary beverage. The olive oil actually has 25 times the energy density of the sugary beverage, but the sugary beverage is much more strongly associated with weight gain and chronic disease risk in observational studies and also in clinical trials than the olive oil. Quite to the opposite in olive oil. People who are consuming more olive oil tend to be, if anything, healthier in the best cohort studies. And let's consider a third tasty food, baked potato chips. Now, potatoes have to be cooked to be consumed. So now, in this case, this is minimally processed. It's just sliced and baked. The baked potato chip still has much lower energy density than the olive oil, but it resembles much more closely the sugary beverage in tendency to promote weight gain and increased risk for diabetes and cardiovascular disease. I doubt whether this notion of palatability would even pass the taste test, if I can use the expression. Does the US lead the world in obesity because we have the world's tastiest cuisine? I think the Italians, the French, and the Japanese might debate that assertion. And think of the implications that in order to prevent inexorable weight gain from year to year, we have to eat only a monotonous, bland diet. So something doesn't quite make sense there. So another possibility for the difficulty of the energy balance model to translate into effective treatment is that it's really complicated. This is the UK government's obesity system map, which shows hundreds of relationships among a variety of dietary, physical activity, socio-demographic, behavioral, economic factors. And if you look very closely, they all converge on energy balance in the middle. Now, this map may be useful as a compendium of all possible relationships, but it's not an experimental testable model of obesity. Experimental models need to focus on key causal drivers, both to inform research, but also intervention. So you can reasonably create an intervention for childhood obesity that focuses on sugary beverages, reducing sugary beverage consumption, increasing fruits and vegetables, and decreasing television viewing. So that's simple. It's testable in a model as to whether those are important drivers, and it's practical. Whether or not it works, it's a practical intervention. There's no way that one could begin with this map in producing any kind of intervention that would have practicality in the public health or the patient care setting. So clearly, obesity risk on an individual basis is affected by biological and genetic factors. No doubt about that. Everybody agrees. But the puzzle that remains unsolved is what environmental factors have driven BMI up year after year among genetically stable populations. Why is a typical man today defending a body weight of 195 pounds with the same genetic risk as the typical male in the 1960s had when he was defending a body weight of 165 pounds? If you took the average 195 pound male today and reduced weight through calorie restriction to 165, he would feel very unhappy. High levels of hunger, his energy expenditure would slow down. And once the external energy restriction was lifted, weight would probably go right back to 195. With its assertion that all calories are alike to the body, the energy balance model implicitly rules out the most plausible environmental factor that could be altering body weight control, which is dietary composition. In fact, I'll argue that the energy balance model, as it's currently interpreted, is inherently uninformative. It's a tautology that restates a fact of physics and lacks a biological focus and gets confused about causal direction. Equating a positive energy balance with body fat storage, as in all of those statements I showed you at the beginning, is meaningless. I'll go so far as to say it's been a colossal waste of time. It's like conceptualizing fever as a problem of heat balance, too much heat in the body, not enough heat out of the body. Now, of course, fever can't develop unless the body generates more heat than it dissipates. But this fact is so obvious, textbooks on fever don't have to reiterate that. We don't have to continue to instruct patients in this fact. This is a fact of physics. It's not a biological explanation. So what we really need to do is examine cause and effect. And for that, we have to get rid of these equal signs and explore causal direction. Do the arrows flow from left to right or from the right to left? Does a positive calorie balance cause body fat storage? Or does increased body fat storage cause a positive energy balance? Both possibilities adhere to the law of physics, but they have radically different implications to how we conceptualize obesity and how we would approach treatment. Consider the example of an adolescent growth spurt. A teenager might consume hundreds or 1,000 calories more a day than he or she did before the growth spurt. But does this overeating relative to earlier habits cause the adolescent to grow rapidly? Or does the rapid growth and deposition of calories into new body tissue cause the adolescent to feel hungry and subsequently eat more? The energy balance model characteristically, it either proposes an equal sign, or when it's addressing causality, it exclusively does so with the arrows flowing from left to right, that overeating causes excessive fat storage. An alternative model, which is again perfectly consistent with physics, the carbohydrate model, suggests that the action's at the right, not at the left. Causality is here. That obesity is, at least for many people, a metabolic storage disorder. Something has triggered fat cells to store too many calories, leaving too few in the bloodstream. The brain set at least at key points in the postprandial process. The brain recognizes that. That's why we get hungry and tend to eat more. If we try to limit food intake with a calorie-restricted diet, energy expenditure will reduce. And thus a positive energy balance will be a downstream effect, not a primary cause. And what could be triggering this body fat storage? Oh, and let me just say that if this is the case, then focusing downstream is the definition of symptomatic treatment. It's not addressing the cause and therefore is not likely to be effective over the long term. So what could be triggering fat cells into this excessively anabolic state? That's endocrinology 101. The most likely player is insulin. Insulin regulates the availability of all of the major metabolic fuels. States of increased insulin action are consistently associated with weight gain, such as someone with diabetes overtreated with insulin or begun on insulin after oral hypoglycemics or other dietary measures fail. And states of decreased insulin action are associated with weight loss, such as a child with type 1 diabetes at diagnosis before insulin is started. What could be increasing insulin secretion? Well, that's nutrition 101. All the dietary carbohydrates, especially the processed carbohydrates that flooded the food environment during the low-fat years. Both the total amount as well as the type, characterized by the glycemic index, which is a measure of how rapidly controlled amounts of carbohydrate digest, raise blood sugar, and consequently raise insulin. Glycemic load, which was first proposed by a collaboration at the School of Public Health here, represents the average glycemic index of a diet times the amount of carbohydrate. And this best predicts how blood sugar will actually change after typical meals as they're consumed. The key points here are that the high glycemic load foods are processed grains, most potato products, and added sugar. Low glycemic load carbohydrates include minimally processed whole kernel grains. So not things that say whole wheat on the package of the bread. It's the way grandma used to make oats, such as Irish oats or steel cut oats, much more traditional, less processed. So it takes longer to digest. Whole fruits, beans, and to the degree that dairy products have carbohydrate, these are low glycemic load. Let's have a look at how glycemic load and index affects hunger and metabolic mechanisms over an acute time frame. In this study, we looked at 12 adolescents with obesity in a crossover fashion, bringing them into the metabolic ward on 3 separate days. And we gave them, on one day, highly processed carbohydrate, which was instant oatmeal-based breakfast. Second day, steel cut oats, same macronutrients, basically identical foods, just differently processed with regard to the carbohydrate. And on a third day, a vegetable omelet with fruit that had more fat, less carbohydrate, and more protein, just to see what would happen if we maximized effects. But these two are the more controlled comparisons. We measured blood and hunger for the 5 hours after the breakfast, gave them an identical meal at lunch, and then measured ad libitum food intake. And here's what we saw in terms of hormonal response. This is insulin and glucagon in the 5 hours after the test breakfasts. As expected, insulin rose higher after the instant oatmeal compared to the steel cut oats or the vegetable omelet. And glucagon, which is sort of the counterpart to insulin. Glucagon is a catabolic hormone compared to insulin, which is anabolic. Glucagon pulls calories out of storage as opposed to insulin, which pushes calories into storage. A high glycemic load, actually, the meal suppresses glucagon. So you have in effect, a metabolic double whammy with these two opposing effects, such that the nutrients of the meal after initial absorption get directed into storage, muscle, liver, and fat, and then blood sugar tends to come down into a relatively hypoglycemic range in the late postprandial period. And at the same time, free fatty acids, which is a key metabolic fuel, are also suppressed. So same calories at the beginning of the meal, but different metabolic states a few hours later, which the brain recognizes as a metabolic stress. Epinephrine, an emergency counter-regulatory hormone, was secreted to a much higher degree after the high glycemic index meal than after the other two meals. And when we gave subjects free access to food, perhaps not surprisingly given the metabolic data, they ate 500 to 700 calories more over 5 hours after the high glycemic index meal than after the other two meals. Now, admittedly, this is a short-term study, and I've argued just a few moments ago that these short-term studies have to be interpreted cautiously. So let's begin to examine potential longer-term translation. To do so, we first looked in an animal model, Sprague-Dawley rats in this case. We gave them identical diets controlled for macronutrients. The diets differed only in the glycemic index of the starch. Amylopectin, which is fast digesting, high glycemic index, versus amylose. Further, we pair-fed them to keep their weight the same between both groups, and measured body composition after 18 weeks, which is a relatively long time in rodents. Rodents live 1 to 2 years. So we measured their body composition with tritiated water. This slide shows the change in body weight among the two groups, the low and the high glycemic index. And you'll see that the weight curves were essentially indistinguishable. But to accomplish that, we had to begin restricting calories in the high glycemic index group. That group began to gain weight excessively on the same number of calories, meaning its energy expenditure was dropping. And we also know from other studies that its physical activity level was beginning to drop. So to avoid excessive weight gain, we had to put it on a calorie-restricted diet. By the end of the study, it had consumed, the high glycemic index animals had consumed substantially less total energy than the low glycemic index animals. And despite that, they had 70% more fat at the same weight. And so they had a commensurate reduction in lean tissue. Now I'm going to show you one graphic slide. These two animals weighed the same, and they actually have similar genetic risk for obesity. The one on the right ate less than the one on the left, and yet it was massively fatter. I'll propose that there's no way to explain this finding based on the conventional energy balance notion that considers all calories metabolically alike, at least in rodents. The question is, does this happen in humans? But in rodents, I think this is it doesn't necessarily mean that glycemic index was the only causal factor here. There could have been microbiome changes, other factors involved. But for an animal to consume fewer calories and be fatter is a proof of concept kind of experiment that energy intake, calorie intake, is not explaining the full range of variance for weight gain and fat gain in experimental animals, at least. So what about humans? The meta-analyses of low carbohydrate versus low fat diets among outpatients tend to show advantages, and all of these show advantages for the higher fat versus the higher carbohydrate diets. And that's opposite to what was believed 2 or 3 decades ago based on notions of energy balance. Now, these differences are not large. They are typically about 2 kilograms. But these are also very low intensity interventions where adherence to the dietary prescriptions tend to be poor. So this does not tell us what the potential magnitude of difference could be, but it does, I think, contradict the notion that reducing energy density, reducing dietary fat, is going to have any meaningful benefit to body weight. What about metabolic effects in humans over a relatively longer period of time? To examine this issue, together with Kara Ebling, our group conducted a large feeding study in which we brought we examined 164 young adults with overweight, or obesity. We first gave them a run-in diet in which we prepared all of the foods delivered to their homes to produce around a 10 to 12% weight loss. Then we stabilized them by increasing calories, adjusting it as needed, and randomly assigning these individuals to high, moderate, or low carbohydrate diets, again with food provision, for 5 months. During this period, we adjusted calories to keep weight stable as best we could, and we accomplished that for the majority of people in this test phase remained within 2 kilograms of their weight loss anchor. The diets were 60-40 and 20% carbohydrate versus 20-40 and 60% fat, with protein controlled at 20% across the board. And as a secondary outcome, we looked at total energy availability in the blood around the postprandial period and saw similar findings to that breakfast cereal I presented earlier. In the fasting state, people on the high carbohydrate diet had somewhat lower calories in the blood. There was a rapid surge by about 30 minutes after eating that diet, but then a tendency to fall off into a relatively low range in the late postprandial period. And this slide shows our primary outcome, which is change in total energy expenditure by doubly labeled water over the 20 weeks of the weight maintenance phase. Those in the high carb group showed no change in energy expenditure. Those in the moderate carb group showed about 100 calorie a day increase. Those in the low carb group showed about a 200 calorie increase. These were highly significantly different. We put the data open, publicly posted. At least one other group did a reanalysis, and we responded. published additional analyses, and it seems that whatever way you can twist and turn these data, the findings are basically robust. And they're consistent with all of the longer term studies. Most studies, this is a meta-analysis that we did recently, published last year, in which most studies of this effect are very short. In fact, most of them are less than 4 days. And that's not enough time to adapt, importantly, metabolically. When one decreases carbohydrate, the body has to upregulate fat metabolism. If it's a very low carbohydrate diet, that includes ketones. Ketones, even with complete starvation, don't reach steady state for at least 3 weeks. So these very short studies are looking, in our view, at epiphenomena or a transient phenomenon before the body is adapted. Among the studies that are at least 2.5 weeks, they all show an advantage for energy expenditure for the low carbohydrate versus the high carbohydrate group. Our study here fell really very much in the middle of this range, so it was by no means an outlier. So I've argued that the processed carbohydrates that increased in our diet during the low-fat era has increased insulin secretion, suppressed glucagon secretion, and promoted a tendency toward increased fat deposition. So as the calories are coming in from the meal, more of them wind up in the fat cell for storage. There are fewer calories available for the body, and the brain senses that, increases hunger, we tend to eat more, or energy expenditure is suppressed. But I want to emphasize that this is, despite its, models have to have a name, but this isn't a one macronutrient, one hormone model. It's an infrastructure for seeing how a range of dietary and environmental factors could be triggering changes in substrate partitioning that could drive obesity, with food intake not being a primary effect, being a downstream effect. And in addition to other aspects of our diet, fatty acid type and amount, protein type and amount, micronutrients, phytochemicals, of course, the gut microbiome, sleep, stress, and physical activity could have effects on substrate partitioning, as might endocrine disruptors, which have received some recent attention as with well-described mechanisms that are directly pointed at the fat cell. Now, during this talk, I've focused entirely on mechanisms that involve insulin and glucagon at carbohydrate amounts down to about 20%. At more restrictive low carbohydrate diets, especially below 10%, one begins to elicit ketones as an alternative fuel for the brain when the amount of carbohydrate consumed isn't sufficient to fuel brain metabolism. And these ketones may have other biological effects that can help shift substrate partitioning, either directly, actions at the fat cell, actions involving inflammation, DNA expression. Ketones are histone deacetylase inhibitors. They alter cellular redox state. But there have been some major reviews of this of these mechanisms recently, and I don't have time to go through this today. So there is at least some evidence for a number of specific predictions of the carbohydrate insulin model, some of which I've presented, others I haven't presented to you today because of the short time frame. High fat versus low fat diets result in more weight loss in clinical trials. High glycemic load foods, sugary beverages, refined grains, potato products, are associated with relatively higher rates of weight gain than some of the highest fat and highest energy dense foods around, like olive oil, full fat dairy products, avocado, even dark chocolate. We've looked at reduced metabolic fuel concentrations in the late postprandial phase, alterations in fuel partitioning, increased body fat accumulation in animals independent of calories, or despite calorie restriction. I didn't show you the evidence that individuals with high insulin secretion seem to be more susceptible to the effects of a high glycemic load diet than those with low insulin secretion, and the possibility of calorie-independent effects on energy expenditure. With recent attention to the carbohydrate insulin model, there have been a flurry of papers claiming to have disproven or falsified the model. One review said the carbohydrate insulin model fails. Another, these data collectively have been taken as evidence of experimental falsification of the model. A third review said important aspects of the model have been experimentally falsified. Now, I won't have time to go through these criticisms, but we've discussed them in our recent paper, and I would argue that they typically involve reiterations of misinterpretations of weak evidence. So there are animal studies that have been cited, but they typically include unphysiologically high levels of saturated fat. In fact, in the most commonly cited study, saturated fat and sugar made up most of the calories in the low carb diet. And saturated fat in rodents is highly inflammatory through toll-like receptor 4. It's very clear that where saturated fat has some inflammatory effects on a conventional diet in humans, it produces severe hypothalamic inflammation, systemic insulin resistance, and could promote obesity through mechanisms consistent with a carbohydrate insulin model, not opposing it. I mean, I think if we were to reverse this and point to the many studies that show you can make a rodent fat on a high carbohydrate diet that's loaded with sugar, well, the proponents of a high carbohydrate diet wouldn't accept that as a fairly controlled study. And I think we've got the same problem here. A second line of evidence, which I consider weak, are these very short ward studies, typically 2 weeks, sometimes just a few days. It clearly takes several weeks to adapt to changes in macronutrients. The short studies are going to inevitably favor the high carb diet because most people starting studies are consuming high carb diets. Most volunteers are selected from the general population. And so that adaptation to a change in macronutrients is going to bias against the low carb diet for a few weeks. So I think that they really have to be interpreted with a high level of caution. And then I've commented on the low intensity behavioral trials that for the most part, although not exclusively, haven't been able to sustain dietary adherence. To put this into perspective, to produce obesity by age 50 from childhood requires the storage of just 1 excessive gram of fat a day. So 10 calories a day shifted is basically that would be the whole story for most people with obesity. In view of that, we need metabolic feeding trials that are long enough to allow for adaptation and that can pick up relatively subtle but chronically important effects. So I'd say for metabolic ward studies, we have to go at least 1 month. Now, that's logistically challenging, but there are innovative design mechanisms where you can bring people into group homes and monitor their food intake. But these studies are clearly difficult, but the difficulty of the experimental design cannot be a rationale for using weak studies to come to causal conclusions. We need behavioral studies, at least a year, with sufficient intensity to promote long-term adherence. And that might include food provision, much more regular meeting with behavioral therapists, dietitians, and the like. And then also cohort studies, ideally begun in childhood, looking at mechanistically oriented outcomes, and ideally 10 years or longer. We proposed a mechanistic model of the carbohydrate insulin model to promote scholarly discourse. We explicitly state that this model is not likely to be correct in its entirety. But we need a specific model so that people can design experiments and either show certain areas are correct or certain areas are incorrect, or build new models. And we specifically call for common ground in collegial discourse. As mentioned, we acknowledge that this model is not going to be precise or accurate, and it does not preclude the existence of other causal influences. We call for additional research that can point the way to new explanatory models that might incorporate aspects of both. Now, in the last couple of minutes, I just want to point out that there's already a basis for thinking of common ground. The energy balance model would typically, not always, but typically point to a higher carbohydrate diet because it's lower in energy density than fat. The carbohydrate insulin model would typically point to a higher fat diet because fat has no effect on insulin secretion. And another model, which I didn't discuss, a protein leverage model, would point to the third macronutrient, protein, as having special benefit for weight control. All of these would agree, in principle, that sugar is an issue. Sugar is highly palatable through hardwired mechanisms. An infant is born with an innate preference for sweetness. So it may be that sweet taste and the hedonic reward that ensues promotes initially a positive energy balance. Then the sugar triggers fat cells into a more anabolic state that accelerate fat deposition and further stimulate food intake, or at least the desire for sweet foods. The protein leverage model might consider sugar as diluting protein and thus also to be avoided. And then ultimately, we want to think about ways that biological variability might help us push in one toward one model or the other for specific individuals. Some people who are low insulin secretors, insulin sensitive, may do relatively better with a prescription that's informed by this model. Maybe as people age, they become more insulin resistant and more metabolic dysfunction develops. The carbohydrate insulin model might have some special applicability, or the protein leverage model. And then ultimately, we want to consider how behavioral aspects, cultural preferences, economics, and the environment interact as we design bigger models that take into account the widest range of variants, and we need all the help we can get to address the epidemic. So I'm going to just skip over my conclusions. I think I kind of drilled them in, but I do want to finish in my last literally two slides with the thought that these ideas may be provocative, but they're not new. So one obesity expert said the following: the current energy theory of obesity, which considers only an imbalance between intake of food and expenditure of energy, is unsatisfactory. An increased appetite with subsequent imbalance between intake and output is the consequence of abnormal fat tissue rather than the cause. So this was said by Julius Bauer in what's now JAMA Internal Medicine in 1941. And then lastly, another quote: calorie restriction reduces the weight of anyone, obese or lean, regardless of metabolic status, by opposing the homeostatic mechanisms for maintaining energy balance. A more rational form of treatment would be one which would enable the organism to establish a homeostatic equilibrium between intake and expenditure at a normal level of body weight. The use of a diet allowing an ad libitum intake of protein and fat and restricting only carbohydrate appears to meet the qualifications of such a diet. And this was Pennington in 1953 in Chris Duggan's journal. Thank you very much for your attention. Please follow me on social media, and I look forward to hearing again what we got right, what we got wrong, and how we can move the debate forward in a constructive fashion.
It was great. Let's open this up for questions now. I suspect there may be a few.
Hi, thank you for the wonderful presentation, Dr. Ludwig. Just for a little bit of background to frame my question, I am a dietitian, and a lot of my patient work has been done with intermittent fasting and carbohydrate restriction, sometimes ketogenic, depending on what the issue is. I saw a trend in my patient population. I'm wondering if you can answer as an endocrinologist and also from your research experience. I wrote it down so it can make sense. So the question is, there is a whole foods plant-based diet approach that's taking popularity, despite starches having a high glycemic load. How do you explain the reverse ratio of high carbs while coming from whole food sources and low fat and its effect on insulin, especially those who are able to clinically reverse type 2 diabetes on this type of diet?
Thank you. Really good question. So I want to first off emphasize that there has been some polarization for a lot of reasons in this debate, but one is the notion of vegan versus carnivore, which is irrelevant to this debate.
Right.
That one can reduce glycemic. You can have a low-fat animal-based diet with fat-free cream, fat-free cheese, egg whites, and dry chicken breast. Or you can have a high-fat vegan diet with tofu, avocado, olive oil, and if you add in dairy, you can certainly cover a range there. Many traditional vegan diets today are recognized, Neil Bernard certainly advocates against high glycemic index starches and sugars and whole, minimally processed grains. Yes, the glycemic load will be higher, but the glycemic index will be substantially reduced. And I think for people who are generally lean, physically fit, insulin sensitive, that diet's probably consistent with excellent health. My concern is the U.S. population, so not a subsistence farmer in China who's 12 hours in the fields a day, but the American who is or at least overweight, sedentary, insulin resistant, and inflamed. My concern is that the high carbohydrate diets, as recommended, are really a recipe for trouble.
Your point that you made earlier that the ketogenic diet can also be a vegan diet and be very healthy. That if you just describe lots of vegetables, pescatarian, throw in some fish, nuts, soy products, and healthy oils like olive oil and other plant oils, and you can have a ketogenic. Even that extreme diet can be a healthy diet. The popular form, apopular form, of course, is probably not a very healthy diet with lots of red meat and high saturated fat, low polyunsaturated fat. So there's, just like on the more vegan end, there's a huge spectrum.
And those are the extremes. Like for most things, you get 50% of the way gives you 90% of the benefit for most people. So I think we all can probably agree. Some of the critics, I was surprised because 25 years ago, people were saying, eat all the sugar you want, basically. I mean, those are the quotes. Now people are criticizing the carbohydrate insulin model by saying, well, we all agree that sugar and refined grains aren't helpful. So why do we even have to, contrast these models, which to me, I find, surprising. We are scientists. We are interested in mechanisms. But I think if we just move forward with a focus on processed high glycemic load carbohydrates, from a public health perspective, that's going to be the base of the iceberg.
Thank you so much for your presentation. I'm a dietitian who works at Boston Children's, and I'm very interested in metabolism in general. So I appreciate your viewpoint on this. I have a lot of patients in general who, not necessarily just from Boston Children's, but we know that obviously a lower glycemic diet will increase insulin sensitivity and start with the metabolic kind of rewiring process. And we also know that people who lose significant amounts of weight often will see that the weight comes back, and sometimes they will even gain more weight past their starting point. So my question is low glycemic variety, really the way that patients are going to be recommended to lose weight. So if you have someone who's coming to you saying, like I need to lose weight and nothing's really worked, and they've tried some low glycemic options in the past, would you say that just increasing or decreasing the glycemic load is really the way in order for people to start seeing the scale come down?
Well, I think it's a reasonable place to start, although no healthy diet can ever be defined by one factor. I mean, not even today, not even the most ardent low-fat advocate would say drink sugary beverages all day because it's fat-free. So we have to create sensible approaches. And in the clinic, you have to try something. You try and see. Now you're going to have this challenging integration of behavior and biology, and that's the art of nutrition. The Owl Clinic, that was the focus. That's the initial focus of our dietary intervention.
So thank you, David. I think the evidence for insulin itself playing a causal role in adiposity is pretty strong. I'm convinced by that. Where I struggle is the importance of this postprandial peak in insulin. That if carbohydrates which raise insulin are problematic, why is then not protein, which is particularly insulinogenic, and even more so when combined with carbohydrate? So I wonder how you accommodate this.
Great question. Let's just confirm that you weren't to plant that question, because I love that question. Carbohydrate raises insulin and suppresses glucagon. Remember, the model has the insulin to glucagon ratio front and center. So you greatly increase your ratio. So when you increase fat and decrease carbohydrate, you lower insulin and you raise glucagon, and that really helps. On a high protein diet, you don't lower insulin as much because, as you say, protein is an insulin secretagogue, although typically not as much as white bread. But you stimulate glucagon. Protein is the primary dietary stimulus of glucagon. So the ratio improves the same way. Now, my concern is I think that's probably going to give you the most bang for your buck for weight loss acutely. My concern is that with chronically higher insulin and glucagon than you would have on a moderate protein diet, would that increase risk for cancer over the long term? We're talking 30% protein rather than 15 to 20% protein. That's going to create a higher insulin exposure and a higher glucagon exposure, and we don't know, but it's a testable hypothesis. But protein absolutely works through consistent mechanisms.
I would note this 106 people were watching, which I think has hit a peak for our seminar series this year. So this topic is obviously of great interest to many people. Frank.
Thank you, David. Really fascinating talk, and we should have you come back soon, because as Walter said, you got the largest audience so far. I really like your common ground slide, which suggests that multiple dietary patterns can be effective in terms of weight loss. But as you know, your critics have suggested that your carbohydrate insulin model do not really allow this kind of middle ground to be reached, because what the model is saying that the causal relationship is, I guess, reversed based on the traditional energy balance model. And as you said in the beginning, if you use the energy balance model, this energy in, energy out, the traditional approach is going to be very ineffective, and because the causal relationship is backward. So how would you respond to this critique?
Yeah, well, first of all, I do want to say that I've been surprised by some of the, I think that from perhaps some expected sources, there's been, a strong reaction. I do think that isn't that what scientists are supposed to do on intractable public health problems? We're supposed to suggest new thinking. We, unlike our opponents, are not saying anything is proven or disproven. But there's no reason why causality can't go in both directions. And I see my new friend Torkild, who is Sorensen, who's well known to the department, call in from Denmark in the evening over there. He and I have a paper exploring this, the possibility that you can have a push model based on very tasty foods that are driving calories in, especially in the early postprandial phase. So we eat a lot and it's really tasty and we just overdo it. But that push doesn't stay put unless you have a pull, something that's causing the fat cells to become more anabolic. And so that's where in the late postprandial phase, the effects of high insulin to glucagon are grabbing onto those calories and they're working synergistically. There's no reason we couldn't have both directions. But to argue that, so we're just questioning the unifocus in one direction. And so I think it's the other side that has been making the intemperate statements. When you say that all calories are alike to the body, which frankly, in my experience, 90% of patients think is nonsense from their own personal experience. When you say all calories are alike to the body, you've ruled out the opposite mechanism. And we still have this problem. Why don't calorie restricted diets work? Now, obviously, we all know that there's biology and there's pushback, but what's explaining this uptick of body weight set point year after year? I think a pull model based on hormonal mechanisms is more compelling. So let's keep an open mind that it's more complicated than both. And when, the opponents yell that, that this is polarizing, point out all of the efforts that we're making to recognize that there could be a greater model that would incorporate both.